Bony fractures and delayed presentations. There are a good number of occasions when we'll come across patients, particularly in their older age, who come in and who have been walking on, say, for example, a broken hip. Now, as surprising as this sounds, because one would assume or otherwise consider having broken a hip, it's very difficult to walk on it. Reality is, it isn't. Hence or otherwise we wouldn't see the same presentation. It's what we refer to as a delayed presentation. So the question really is, how does a delayed presentation come about, or how is it that when somebody has broken a hip, you can actually fully weight bear and continue with life, and be presentations as late as 2 and even 3 weeks, which I've seen in practice. For anybody who's broken a bone, you will appreciate how painful this is. So again, for those individuals that is of particular interest as to how it is possible really that somebody is fully weight bearing and continuing with their life and their activities of daily living. So in order to understand this, what we really appreciate is that the demographic here, what we are referring to for the most part of it, is generally our elderly citizens, so perhaps over 65, 70 years of age. And why is this important, or why is this even relevant? Well, the relevance here is partly because, first and foremost, patients in that age group do not experience pain or do not perceive pain, rather, in the same way as somebody of a younger age does. And why is that? Well, that's because as part of the natural aging process or otherwise, there are fewer receptors that will actually perceive that pain. So the nociception is therefore somewhat compromised. The other reason for this also is because patients in that age group have some degree of peripheral neuropathy. What does that mean? Some of their nerve endings are not quite as tactile, they are not quite as sensitive, they are damaged perhaps due to the many years of physical insert, i.e. pressure if they were manual labourers, or even otherwise in the absence of that. So the nerve endings are not quite as tactile, and so therefore the pain is not perceived in the same way. This is very much the case, and yet again we look at the same demographic, where a good number of patients may well be suffering from some sort of actual peripheral neuropathy, such as what we might see in diabetic patients. So diabetic patients may have what we call diabetes-induced peripheral neuropathies or diabetic neuropathies, in which case the diabetes has had an impact on the nerve endings, causing denervation. So all these circumstances, patients won't necessarily feel pain in the same way as somebody whose sensory endings are still completely intact. So that's part of the reason. The other reason really, as we see it, is mechanical explanation itself. So what you usually find in these situations is that the patient has had a fall, say 2 or 3 weeks prior, and they've got up and they're mobilized and they've continued with life as normal. The break did actually more than likely happen then, or in fact, given the trauma and given the predisposing factors of various sorts, including osteopenia, osteoporosis, which is reduced bone mineral density, actually happened. However, what's important is that the bones, once they broke, did not displace. Displacement is what we refer to as movement of the two fragments that have actually broken. So we measure fractures as fractures with displacement or fracture without displacement. There are various types of fractures, and that's beyond the limit or the remit of this talk. Here, the displacement is important or of relevance. Patients under those circumstances will have fallen. There will be no displacement, not even minimal, but no displacement. And because there's no displacement, the nerve endings in the periosteum haven't been exposed or been disturbed. And as such, the patient experiences no real pain. Perhaps a bit of discomfort, but nothing disproportionate. So they, like I say, continue with their daily active living until what they then do is either they have a second fall, therefore some serious physical trauma again. It does not have to be serious. It could be trivial. In that age group, a fall is a fall, enough to cause displacement of the bone, and then they will not be able to get it. Or what you, again, in some cases I reflect on, patient has gone and sat in an armchair and they're no longer able to get out of the armchair, and they report the classic clinical manifestations of a broken hip or otherwise. And it is those circumstances where we say, okay, let's now contextualize clinically exploration of their preceding history of the fall, contextualized with the clinical presentation, and you come to find that actually they were at risk of having broken a bone. There has been a break perhaps then, and what we now see is we do the x-ray and we see the same break that we were expecting, except with displacement. So the reason these patients actually come in with a late presentation is partially because their sensory the sensory reception is not as intact, so there is some compromise, so their pain perception is not as sensitive as would be in the otherwise healthy individual. And secondly, because the bone that broke, there was there was no displacement, and on the back of this, whatever has happened since, that now has led to their immobility or significant pain. That pain has occurred because the two bony fragments that broke, they have now displaced, and that displacement is now exposing the periosteum, which is the outer layer of the bone, which is extremely highly innervated, lots of nerve endings, and they are very, very sensitive, and that is now causing the nociception, the pain perception. So there you have it, a reason as to why we see late presentations in the generally elder population in such situations. Thank you for watching.